Welcome. I'm Amanda Schnetzer, and today we're talking about youth mental health in the United States. According to the Centers for Disease Control and Prevention, feelings of persistent sadness and hopelessness were up 40% in the 10 years leading up to the global pandemic. Problems only intensified during the lockdown. Mental health-related emergency room visits have nearly doubled. Negative behaviors associated with conditions like attention deficit hyperactivity disorder have increased. And suicide is now the third leading cause of death among teenagers. This crisis is weighing heavily on children, families, schools, and society as a whole. To help us understand what's happening, why, and what can be done about it, I'm joined today by three distinguished experts. Dr. Michele Forbes is a pediatrician and chief medical officer for the Catalyst Health Network, the largest network of independent primary care physicians in Texas. Dr. Jacquelyn Gamini is a neuroscientist and director of the Adolescent Reasoning Initiative at UT Dallas's Center for Brain Health. And Kacie Kelly is Chief Innovation Officer with the Meadows Mental Health Policy Institute, which works at the intersection of mental health policy and programs. Kacie, let's start with you. The data that I just shared are pretty alarming. Can you help us understand how widespread is this phenomenon, or is it affecting certain regions or communities more than others?
Unfortunately, you're right. Children and youth are facing a growing and unprecedented behavioral health crisis, and it was amplified by the pandemic. But we are honing in on some areas that are particularly ripe for focus. We know that most behavioral health conditions begin in childhood, with 50% of all lifetime illnesses beginning by the age of 14 and 75% by the age of 24. And so we think that that particular age range could be our window for intervention in the future. Meanwhile, though, we're also dealing with a severe behavioral health workforce shortage. Right now we have real difficulty in meeting the demands that are out there. For example, it's an average of 10 years before youth can access care after their symptoms first persist. Particularly troubling for youth living in rural areas, youth of color, or those who identify as LGBTQIA, with more than half of U.S. counties lacking a single psychiatrist and only 1 in 10 practicing psychiatrists being from racial or ethnic minorities.
How does that align with your experience on the front line of providing primary care and working with other physicians who are providing primary care around the state of Texas?
Right. I can echo what Kacie said, and I really love the point that she made about that window of opportunity. And so what we did in my practice was screen all our patients starting at age 9 for mental health conditions. And over 20 years, my practice transitioned from lots of happy babies, well care, to over 75% of my practice handling mental health conditions. So she's right. This existed before the pandemic, was exacerbated, but that was my experience, is the need was there. We identified it with screening, but the capacity for community resources, mental health resources, were lacking.
Can you say a little bit more about the capacity for mental health resources? The data we've looked at already today give us a sense of the impact on children and on families, but it's also having an impact on the healthcare workforce across the board. Can you say a little bit more about what that looks like in your own practices that you work with?
Sure. There is a lack of access. One of the things that we did in our practice, which I was really, really excited about, is we practice collaborative and integrated mental health care. So in our practice, we had a pediatric psychiatrist who we could perform a warm handoff of our patients to. But there was still a need that was somewhat met by community resources, and that was the collaborative aspect. So we needed talk therapists. We needed therapists who could address our issues in a non-pharmaceutical way. And so we really worked to create that access in our practice and learned lots of lessons and identified lots of opportunities to improve it.
Are the stressors different today than they were 15 or 20 years ago? What is affecting and driving some of the change and how children are able to respond or cope with these stressors in life?
I think one of the most difficult problems is we are inundated with information. As adults, we are bombarded with information all the time. And adults sometimes forget that children don't have the ability to reason through a lot of that information, really sort it, think deeply about it, and be critical about what they're hearing. And so they feel overwhelmed a lot of times, which adds to the stress and the anxiety that they're feeling.
I know as a parent, one of the stressors that I worry about a lot with my teenage son is social media. We talk about it all the time. And I know other families are concerned about it too. Can you talk about the impact that social media and being online in general is having that is, say, different than even a generation ago?
Right. Well, social media is raising the expectations for children of what is normal, what is appropriate, what is real. And so, they're trying to live up to these expectations, and that really induces a lot of additional stress and anxiety that they can't be perfect. They may not know the perfect dance or the perfect moves, but they try very hard to emulate what they see, and it can be very frustrating for them. And the environment is what changes and shapes the brain, and so if children are being inundated with social media aspects that they are not completely able to handle, the brain begins to develop differently. I don't think we yet know what those ramifications are going to be long term.
Thank you. I mean, the environment during the lockdown of the global pandemic certainly changed for all of us, and especially for young people. Kacie, I'm wondering if you can speak to how the pandemic really changed the environment and created either new stressors or exacerbated ones that were already there, like social media and the amount of time maybe that young people are spending online.
Well, I think Michelle's exactly right. Like, there's still a lot that we need to learn. If you pay attention to the press, you might be thinking, on one end, social media is the root of all the things that are wrong. But on the other end, you hear organizations like a recently announced collaboration of 14 youth-led organizations that have united to fight for inclusive and equitable technology into the ecosystem, with the notion that there's some tech platforms that can be used for good, while we also do need to pay attention to those harmful risks and impacts and mitigate those risks. And I think we're only beginning to understand the impact of technology on our youth, as well as the isolation that our youth felt during the pandemic. And so, I'm really encouraging us to ask more questions and to be data-driven as we approach policy recommendations in the future.
I always love a good reference to data. And one question I'd like to ask you, Kacie, just as a quick follow-up is, I'm sure some viewers may be wondering, well, it's great that children and youth are speaking more about their mental health challenges, that they're involved more and more proactive about seeking help, or at least that seems to be the impression we have. So is it the fact that there's a greater mental health challenge and we really are in a crisis? Or is it simply a matter of we're more open and transparent in talking about these issues? Or is it somewhere in between?
I think it's somewhere in between. Amanda, I most of the time I've been working in mental health care operations and policy for 22 years, and most of the time I feel more hopeful than ever before about the phase that we're in, because more people are talking about it. We have more evidence-based solutions at our fingertips, and we have more people raising their hands to be part of the solution, whether it's a policymaker or an investor or a direct service provider. And so that gives me a lot of hope that we're really at an inflection point, and not only offsetting the trajectory that we're on, but actually identifying some transformative solutions that will be put to use to empower more to thrive and not just survive related to their mental health care.
That's really insightful. I would love to ask Michele and Jackie, both of you, since you interact with young people in different ways in your own professional life, are there signs of things already that give you hope? I know there is a lot of concern to talk about, but let's have some hope. So Michele, I'll start with you. Are there signs that you see, even if they're small green shoots of things that give you hope right now?
Yes, the aspect of my practice that really shifted to mental health gave me hope because we were screening and parents were interested in the whole kid, not just physically, but my parents and their children were very interested in whole health. And, that's huge. And as Kacie was saying, there were some things we lost during the lockdown. And it's important. I think about this when I put my pediatrician's hat on, right? So there are developmental stages that each kid has got to go through, and they don't go through them in isolation, and they don't go through those stages successfully engaging with social media. And so there is opportunity to revisit, as best we can, ameliorate those developmental stages that were lost. So the fact that we are sitting here and talking is a green shoot of hope.
I love that. Jackie, what about you?
Well, with my work at the Center for Brain Health, we go into schools and we work with teachers and children, teaching them higher order thinking skills. And some of our evidence shows that when children are not just overly focused on details, that they actually begin to see the bigger picture, and there seems to be a reduction in some stress and anxiety and depression for some of these students. So I think that's very hopeful for sure.
So are you giving me extra ammunition with my 14-year-old that it's okay to be bored and not?
Yes. Boredom is good. Boredom leads to creativity. Yeah.
I love that. I love that. Well, you've led us into a great part of this conversation. We've talked about the origins of the problem. We've talked about the size of the problem, and it truly is weighty, and it's also comforting to be able to find those green shoots of hope. But let's dig in further into what we can do about it, because that's what makes me happy, and I think is where people are really probably wondering, what can I do? What's already being done that is working? And so let's dive into some of the important work that all three of you are doing. To help us get started, I want to share a quotation from Dr. Brock Chisholm, who was the first Director General of the World Health Organization. And he said, without mental health, there can be no true physical health. So that connection that both you, Kacie, and Michele have already been making and talking about collaborative care, or the integration of behavioral health into healthcare is really important. And so I would love, Michele, to have you say a little bit more about what you have learned in architecting sort of the integration of behavioral health care into healthcare, both in your own practice and how you're continuing to figure out how you can scale that in a much larger way right here in the state of Texas.
Right. That scaling is important. I like the way you phrased that as well. I think it's been an uphill battle to recognize that the brain is connected to the body. So this is all health. Appreciate you highlighting that. But I talked about what we did in our pediatric practice, where we had a psychiatrist embedded in our practice and learned lots of lessons. First off, for that to be successful, it has to be scalable because of the way healthcare is financed, right? Somebody's got to pay for it. And I'm really excited that part of my role as Chief Medical Officer at Catalyst is exploring this conversation with our almost 1,000 primary care physicians, right? So we have the opportunity to share that resource, a psychiatrist, psychologist, talk therapist, among our 1,000 members. And so those represent almost 1 million patients. And so having it's more collaborative, integrated into our accountable care organization so that our members' patients have access. I'm really excited about that, and I'm interested to hear. I know that you've got some experience with collaborative.
Yeah, I mean, I love to hear you say, when you say 1 million patients just in the state of Texas, it reminds us how big this state is, and yet we live in a very big country. And Kacie, I know that your work at Meadows, you're working at local, state, and the national level on some really important initiatives, including around collaborative care. Can you say a little bit more about exactly what collaborative care means? We've sort of highlighted it a little bit here, and what you're working on to figure out how we get this kind of care at scale. What's it going to take to get it at scale in Texas and in this country?
Thanks for that question. So the Meadows Institute is leading a range of projects, both on the policy side as well as the program implementation side, to integrated care models into care systems. And we have a lot of investment and a lot of work right now happening with the collaborative care models specifically. And part of that priority for us is to advance the early detection that I referenced earlier, that is really missing. And we believe that our mental health community overall did a big disservice to us by taking mental health or sending a message decades ago that mental health needed to be put over here on the side of healthcare as opposed to treating it the way we treat the rest of mental health care. And so we are working to transform health systems in Texas in both pediatric and primary care settings. We're in about 60 healthcare systems right now doing technical assistance, supporting the busy practices with helping them to understand how to change their operational workflows, things like understanding how to bill for this specific model. Collaborative care is approved by Medicare and almost all private health insurances, but unfortunately, only 27 states have approved it for Medicaid consumers. And that's really important when we're talking about the youth mental health challenges we have, because 40% of youth get their behavioral health care through Medicaid. And so if we're really going to expand this model nationally, we do need all 50 states to have Medicaid policies in place that cover this model. And there's been 2 decades of evidence that support the model from a clinical outcomes perspective, but also from a financial outcomes. It actually saves money for our system, which is huge. And we
Kacie,
worked with the common.
Forgive me for interrupting you. I just wanted to circle back on with clinical outcomes, and Michele, I would love to ask you about the financial side of it. Can you give us an example of where collaborative care has been implemented, where this integration is occurring? What does better clinical outcomes mean? What are you looking for? What kind of proof points are you looking for that this is better than at least the status quo that we have today?
One of the outcomes that we are particularly excited about is just the increase in volume of patients that can be seen through this model. So, for example, the model puts a behavioral health care manager in the primary care or pediatric setting with a psychiatrist, remote psychiatrist in most places. And so it supports the primary care physician and the pediatrician in able to ask the questions related to mental health care and help them identify people who are at risk earlier and get them connected to the right solutions at the right time. And on the financial side, it is the research is telling us that it is saving practices 6 to 1 when they are implementing collaborative care at scale.
Michele, you're nodding your head. Can you validate that or affirm that is correct?
Yes, a resounding yes. We had fewer patients going to the emergency room admitted to psychiatric hospitals when we had our integrated psychiatrist in the office. It allowed us, the pediatricians in my practice, to focus on what we really do well: growth, development, keeping kids healthy, and supporting mental health. But we were able to work to the top of our license, our area of specialization. And so we had fewer patients that we lost to lack of follow-up, lack of being able to schedule with the psychiatrist. The wait times are pretty long. And so fewer of our patients went to the psychiatric hospital. Fewer of our patients were admitted. More of our patients were connected with the right resources at the right place at the right time. So yes, I agree.
That's pretty compelling data. I want to turn to Jackie about the other place where our children spend lots of their time. Yes, in the doctor's offices, and yes, at home, but also in school. And we know that schools, teachers, counselors, administrators, and children themselves are really struggling with stress and mental health pressures, and it's affecting everyone in schools. You spoke earlier about the work that you do to help students build problem-solving skills and manage their impulses and learn how to do good planning. How does that have an impact on a child's mental health? Can you connect the dots a bit and about why that's important to be integrated into our schools as well as integrating it into our primary health care?
Right. Well, unfortunately, many educators, they're taught how to teach. They're taught their content, but they aren't taught about the brain or brain development and how important that is for students. You know, if you're told you're wrong, you're wrong, you're wrong, and school is your job, you feel extremely unsuccessful. And just like wanting to feel successful in our jobs, school is these children's jobs. So when we train our teachers more about the brain and how they can influence those cognitive developmental skills such as cognitive control and executive function, we're helping the teachers for many years to come. And they're reaching thousands of students, which is really important. And we know that that children are need to develop these skills in order to be critical thinkers, because they are the future and they're the ones who will be supporting us in our old age.
And that's such an important point. We're so often focused on what do we need now and what solutions do we need now. But this is also about investing in the future, and as Kacie has said, investing early in a child's mental health. And so that's such an important point. Kacie, I am curious, and I think the viewers would be curious and interested to know a little bit more about the work that you also are doing in the schools and how important it is to, or is it, from where you sit, how important is it to prioritize mental health care in the schools, and what does that need to look like?
Well, from our view, prioritizing mental health care in the schools is really about increasing access, going to where we know kids are already going. And we're a proud member of the Texas Child Mental Health Care Consortium, which just received landmark funding from the Texas State Legislature to build out a program that it had established several years ago called the TCHAT program, the Texas Child Access Through Telemedicine program. And it basically provides schools with an easy button to press when they see a youth struggling, and that child will have access to telemental health services through one of the academic medical centers that exist across the state. We have 12 academic medical centers that have united in this mission. And in the 2023 legislature, Texas added $172.7 million to the state budget to make TCHAT available in any school district in the state. And it's now being looked at nationally as an innovative model to help youth access services through schools and let the teachers do the job that they were trained to do. And so we're really excited about the future.
That's wonderful, and very clear that it takes effort and coordination and partnership at the local level, at the state level, at the national level. Well, in the time that we have left today, I want to probe a little bit more in the area of what else needs to be done. Michele, I want to start with you. We're talking a lot about access to care and access to mental health care. There are other issues that stand in the way of individuals and communities being able to access health care, including mental health care. And I know some of your work focuses there. Can you talk to us about some of the issues of equity and access as you see them and as you're experiencing it?
Yeah. I think of them, and I didn't coin this phrase, but as non-medical drivers of health. And so if you think about what Kacie talked about, or you as well, Jackie, are the teachers prepared in the school to address not just the education component, but how their their students' brains are working? But there are other non-medical drivers of health, access to infrastructure, including Wi-Fi in neighborhoods. It's difficult to connect a family to a psychiatrist via telehealth if they don't have Wi-Fi in their neighborhood, right? Other issues are transportation, food. We have Light Path Health. It's a nonprofit that our company started where we are providing access where patients live, work, worship. So we have a clinic in a church in South Dallas. In Q1 of next year, we'll have a clinic in a community center in Oak Cliff. So we're serious about access, addressing equity. We will come to you we will have a clinic in your neighborhood where you go play basketball, where you worship on Sundays, where there is a bus line, so transportation. And we also provide connections to food banks and other sources of inequity that make it really difficult, number one, to learn in school, number two, to pay attention to health. If you don't have lights, you don't have food in your home, it's really, health is a lower priority. And so we're aiming to address the lack of access inequities that exist by going to where people are.
I love that, going to where people are, meeting people where they are. Well, as I said before, one place where people really are is between home and school. And what does that collaboration need to look like, or how could it look differently, Jackie, in terms of steps parents can do, steps that teachers and educators can do to collaborate and meet each other where they are?
Well, I think the greatest need is for children to become more resilient. And a lot of times as parents, we feel that means we need to protect them from harm, of course, but also protect them from failure. And what's really important is for parents to understand that they can reframe failure into something more positive. It's a way to grow, and it's not shameful. We all fail at something at some point in our lives, but understanding that failure is a part of life, and we can go on, and it's not the end of the world. And I think that's the biggest thing that parents can do, is be empathetic, listen to their child, and help them reframe to be more positive about the pitfalls in life.
Thank you all very much for your time. This has been a terrific conversation. The U.S. Surgeon General, Dr. Vivek Murthy, has called for an all-of-society effort to change how we view and prioritize youth mental health. Our young people matter, and they are our future. I want to thank our guests for helping us better understand this growing concern and what we all can do about it, from educators to parents to business and policymakers. And thank you for joining us as we continue talking about things that matter with people who care.